right, thank you, Mary. So as she said, I'm a hospital pharmacist at Aurora Bay Care, located in Green Bay. I live in the Fox Cities. And I've been a pharmacist I graduated in 2010 from University of Arizona, and I've worked in hospital pharmacy since then. And I do have a personal connection with Parkinson's. My father had Parkinson's disease before he passed away. And then my best friend, her sister, has early onset Parkinson's. So definitely have worked with these patients before. I'm in no means an expert, but I'm going to talk today a little bit about the medications that are commonly used in Parkinson's, how they work. And then we'll go into some of the new stuff that's exciting on the horizon that might be out there. So let me just, all right. So for the overview today, we're going to go over the current Parkinson's medications that are used and how they work in the brain, which different kinds of medications are available, some of the side effects they have, and maybe the dosage forms that they're available in. And then the last part, we'll talk about some of that what's new. So there's some new uses of old medications, and then there's new things on the horizon that are being worked on also. So to start with, I just want to get everyone familiar with dopamine. So that's really what we're going to be talking about today for the most part. So this is what dopamine looks like as a chemical structure. So it's a neurotransmitter within your brain. And unfortunately, the way it works is you cannot take oral dopamine and have it cross over into your brain to work there. So your body either has to make the dopamine, or we have to conserve what you have in your body and allow it to work better. So you'll notice when we talk about a lot of the medications, they're going to be either mimicking dopamine, so acting like it. They're going to be stopping the dopamine from being broken down, or just enhancing or in a form of the dopamine that we can actually use in the body. So we'll talk about that as we talk about each medication, and we'll come back sort of to the next few slides that I'm going to show you. We'll keep coming back to those to remind you of where they're working within these different parts of your body. So to start with, I know this one's a little bit busy, but the very top, in the top left corner, that is what a dendritic cell looks like. So that's what your neurons look like within the brain. And then you can see at the end, it's releasing all those little hearts are different neurotransmitters. So dopamine is a neurotransmitter in the brain that's responsible for a lot of different actions. There's multiple ones. So you might have heard of serotonin that you'll hear people talk about related to depression and different things like that. So there are multiple compounds within the brain that do work in different parts and are responsible for very different things. So the bottom left corner is sort of zeroing in on the end of that neuron. So where we saw those little hearts being released from up in the top there, you can see a little closer what that looks like. So we see the dopamine sort of in between the two different cells. So there's the cell that's transmitting the dopamine and releasing it on the top. And then on the bottom is the cell that's receiving the dopamine, and that's where it would actually be working. So you can see there's little purple sort of oblong things that are labeled as dopamine receptors on the receiving cell. And so if you don't have enough dopamine being released from that top part of the neuron, then it's not going to work in that receiving cell. So some of the medications we're going to talk about are going to work on that dopamine receptor that you see in that purple, sort of purple oblong area. Others are going to be responsible for having more dopamine available within they call it the synaptic cleft between those two different cells. And other ones are just going to stop the breakdown of dopamine. So the picture on the right is just showing there's 3 different primary pathways where dopamine works in the brain. So in the blue, you can see what's called the substantia nigra, and that's usually what we see related more with Alzheimer's. The ventral tegmental area in the red, you can see sort of loops throughout the brain. And then there's a green one, that's a tuberoindofundibular pathway. So those are just different places in the brain that dopamine can work. So you can see pretty much throughout the entire brain and the brain stem that's coming out of your spinal cord, there's a lot of different areas that dopamine can work in. So it's a very important neurotransmitter, and it has been linked to Parkinson's disease in that most people with Parkinson's do not have enough dopamine. They're either not making enough, or their body isn't able to use it, or it's breaking down too quickly. So essentially, most of the drugs we're going to be talking about are going to work somehow on dopamine. The next slide I know is really busy, and I will explain what most of these mean as we're going through it. But basically, your body can make dopamine from various amino acids that you eat. So you'll see on the left side where it's saying biosynthesis, that phenylalanine and tyrosine are things that you would eat in foods, amino acids. Your body would then take that, make L-DOPA or levodopa from that, and then that would be converted to dopamine. So that bottom left corner, dopamine, and what we want the most of in our body. So that's what we're going to be concerned with. So we have the one pathway coming downward that's creating the dopamine. And then you can see sort of off to the right are different ways the dopamine is broken down. So we're going to talk about a few of these, and I'll bring this slide back just to remind you, there's different enzymes that work in your body that break down the dopamine. And so one of the ways we're going to keep more dopamine available in your brain is to stop its breakdown. And we're going to do that in a few different pathways. And again, I'll bring this slide back and I'll remind you of exactly what's happening so you don't have to remember any of this. And if you don't understand what all the words mean, don't worry, we will be talking about those as we go. So to start with, we're just going to talk real briefly about the role of medications in Parkinson's disease. So first off, there are no disease-modifying agents at this time. So there is no cure for Parkinson's. What we do with our medications is we help slow the progression of the disease, so keep it at a tolerable level longer, and to help improve the symptoms, which are primarily the motor symptoms that we see in the Parkinson's patients. So some of the tremors, the shakes, the slowing down of everything, the steps, the not being able to have good balance, good gait, things like that. So really what we're doing with those medications is improving quality of life for our patients. We are unable at this time to cure the disease. So as we talked about a little bit in the previous two slides, most of our medications can increase dopamine or stop its breakdown, and we'll discuss that with each different class as we're going through it. So a lot of medications, unfortunately, that we use for Parkinson's are not always well tolerated. So a lot of times they'll delay treatment until those symptoms are bad enough that it's impacting their quality of life. So you may not go on a medication when you're first diagnosed with Parkinson's disease. They may wait until you're showing certain symptoms or certain signs, just because some of the medications we can only use for a certain amount of time, and other ones stop working the longer we use them, or we have to keep increasing the doses. And some of them, the side effects are quite bothersome. So we try and limit that at this point in time. So the first one we're going to talk about, I'm bringing this picture back that we saw before. We're going to talk about things that work on the dopamine receptor. So you see I have it circled here in purple, that the dopamine receptor. So what we're going to talk about are drugs that the body thinks are dopamine. So we call them a dopamine agonist. So it activates those dopamine receptors exactly the same way that dopamine would to get our desired response. All right. So these are usually our first line medications prior to starting carbidopa, levodopa, which a lot of people are familiar with. So we definitely use these in our early onset Parkinson's patients, just because sometimes they can be on medications for so many years. We have to go through multiple drug classes. So this is a very common one we would start with for those early onset patients. We can use it with our carbidopa, levodopa therapy, which we'll talk about next. And basically what these drugs do is they mimic dopamine in the brain. So your body thinks there's more dopamine around. These are turning on those receptors that the dopamine would normally do. And then we're getting control of our symptoms and slowing the progression of the disease because of that. So there are a few different agents that we use. So I've listed them here. So bromocriptine or Parladel, cabergoline or Dostanex, apomorphine, which comes in two different forms. So the brand name is different, apokinin or Kinmobi, pramipexole or Maripex, Rapinirole or Requip, and Retigotine or Nuopro. So these come in various dosage forms. So there are patches. Retigotine is a patch, the Nuopro patch. The Kinmobi apomorphine is a sublingual film you just put on the tongue. There are injections such as the apokinin apomorphine formulation. And then a lot of the others come in tablets like your bromocriptine, cabergoline, pramipexole, and Rapinirole all come as tablets. So we use these medications primarily to allow the doctor to delay starting that carbidopa, levodopa therapy as long as possible. And we can use these in combination. So the one that gets used the most is probably the apomorphine. And that helps reduce what are the off symptoms of Parkinson's. So everybody has periods of the day where their drug starts to wear off. Their symptoms come back. Maybe they were under control when they first took their tablets or their medication, and then they start to wear off, and they call those off periods. So these drugs can be used to help reduce those in our patients when they're taking it. So the apomorphine sublingual films, that's one of the things that they're used for, is when patients start feeling those off symptoms, they can put that on their tongue. It'll help stop those off symptoms until they take their next dose of their next scheduled medication. So just a little bit more about these agents. Adverse reactions. So some of them are easy to tolerate, some are not so much. So the common ones that you'll see are nausea, vomiting, dry mouth, insomnia or inability to fall asleep, peripheral edema, which is swelling in the feet or hands, constipation, fainting, hallucinations, and sleepiness. So you could get either the insomnia or the sleepiness, depending on which agent is being used and how it works in the person. Every person's different, and they respond to medications differently. The most concerning side effects is these patients can develop compulsive or impulsive behaviors. So examples of this would be compulsive gambling, hypersexuality, shopping, compulsive shopping, or impulse purchasing, where they just go in the store and they buy, every single My Little Pony they have in the store. And then binge eating can also be another one. So those are the ones that usually people would stop the medications from, because they can be harmful in other ways to the patients. So we would a lot of times stop the medications for those compulsive or impulsive behaviors. The other thing you do have to worry about with these is something called dopamine agonist withdrawal symptoms, or withdrawal syndrome, or DAWS. So when you're on one of these medications, you can't just stop taking it one day. You have to taper over at least a week, taper the dose down. So if you take 2 tablets a day, you go to 1.5 tablets for a few days, 1 tablet for a few days, a half a tablet, something of that sort. So you can't just stop it abruptly. If you would, you could have side effects of the DAWS syndrome, which include anxiety, panic attacks, insomnia, if sleepiness was what you were experiencing before, irritability, agitation, fatigue, orthostatic hypotension, which means your blood pressure drops when you stand up. So when you first stand up from sitting down, your blood pressure would drop. Sweating and craving of the drug. So an actual withdrawal symptom that you hear about with some of the narcotics or nicotine. You can feel those same drug cravings when you're stopping these medications. So because of that, we just need to be careful that if you do stop this, you do taper these over at least a week, sometimes longer, depending on how long you've been on the medication. All right, so that is the first class that we're going to talk about with that dopamine agonist. We're going to move on now to sort of the mainstay of Parkinson's therapy, and the one most people are probably the most familiar with, which is carbidopa-levodopa. So remember, we talked a little bit about the biosynthesis of dopamine and how it's made. So levodopa, or L-dopa, as it's marked in our slide here, is a dopamine precursor. So that just means in the chemical synthesis of dopamine, when your body's creating it, L-dopa is right before the dopamine. So the dopa decarboxylase that we see here transforms the levodopa into dopamine. So levodopa can be made from amino acids in the body and transported into the brain, where it is then converted to dopamine. Remember I said the dopamine doesn't cross into the brain. So the L-dopa has to be transported into the brain, and then the enzymes within the brain can cause it to be made into dopamine. So we do use a combination tablet. So it's carbidopa plus levodopa. And so your drugs will always have, in this class, will have 2 different strengths. So say 25 milligrams of carbidopa mixed with 100 milligrams of levodopa. So the levodopa is the active agent. Carbidopa is there to help prevent adverse reactions. So if you take oral levodopa, some of that will be converted to dopamine outside your brain, causing adverse reactions. The carbidopa really is there to confuse the periphery, so outside of your brain, is there to confuse those enzymes, and it will act on the carbidopa, which doesn't really do anything, and allow more levodopa to get into the brain. So it's really there to provide a buffer so that you can take less levodopa and have more get into the brain than you would if you did not have that carbidopa mixed in there. So the carbidopa doesn't actually do anything within the body itself for Parkinson's disease. It's there just to help more of the levodopa get to where it needs to be. So there are many dosage forms. So the names that are up top sort of go with the different dosage forms. So Cinemed is our most common with the tablets, either immediate release or extended release. Rytary are the capsules of carbidopa, levodopa. Duodopa and Divi will both talk about a little bit later because they're newer agents or newer dosage forms, I guess I'll say, within the carbidopa, levodopa family. And there are disintegrating tablets in liquid too that you can use. So because there are so many patients taking this and they have different needs, there are different formulations that have been developed for these patients to be able to allow them to get the medication. So maybe you can't swallow a capsule, we have that disintegrating tablet, or maybe you can have a liquid that would be better for you to take based on the symptoms you have or the difference, how progression that you're within the Parkinson's disease. So there's lots of different dosage forms and these can be changed around. Sometimes people have too many side effects at night, so they take an extended release tablet or capsule at night. They use the immediate release during the day. So you can mix or match these as you need to based on the patient and what they need. So the unfortunate thing with the carbidopa, levodopa is your body does become a little bit tolerant to the medication. So the doses and the frequency need to be increased the longer that you take it. So you may start taking 1 tablet twice a day, then you have to go to 3 times a day, then 4 times a day. Then maybe you're taking 2 tablets 3 times a day. The doses have to be increased based on the symptoms of the patient. So if those motor symptoms are no longer under control, the drug doesn't seem to be lasting as long as it used to, you may need a dose adjustment and you'd have to work with your neurologist to make that happen. Unfortunately, that's just something we know happens with this medication. So it's one of the reasons we try and keep people off of it as long as possible. So we use the dopamine agonists that we just talked about first to try and keep them going to the carbidopa, levodopa as long as we can, because we know we're going to have to keep increasing that dose the longer that patients stay on it. Adverse events with this one, there can be some dyskinesias, which are involuntary twisting movements. And then you can have what we talked a little bit about, those on and off motor symptoms, fluctuations. So depending if you're taking the immediate release tablet, we know it only lasts for so long. Once it wears off, your motor symptoms can come back, but maybe it's not time for your next dose yet. So those are times when we also have to either add something else to help control those motor symptoms, or we may have to change the dosage or change how often you take the medication. Some of the most common side effects we see are nausea, vomiting, orthostatic hypotension again, so that inability to regulate your blood pressure when you stand up or sit down, anxiety and hallucinations. You're going to see a lot of these side effects come back just because it's one of the things that dopamine controls in our brain. In some of the pathways it works in is that nausea vomiting center in our brain, the regulation of that blood pressure, and then hallucinations and anxiety, unfortunately, are some things that dopamine can make worse. So the more dopamine we have, the worse those can be. So you'll see a lot of the medications share these similar side effects as we talk about them. All right, moving on, I told you we were going to, so that covered sort of our left side about the dopamine precursors and how to get more dopamine within our body. So having more available so our body can convert that levodopa into dopamine. Now we're going to talk about how to prevent the breakdown. So the first one we're going to talk about are the MAO inhibitors. So MAO is an enzyme that breaks down dopamine and some of the dopamine derivatives. So you can see on the bottom, the first arrow there, that MAO is breaking down dopamine directly. And then sort of up in the middle, the dopamine is broken down into something else. And then the MAO further breaks down. So there's 2 different pathways that we can stop with these MAOI drugs. So it's monoamine oxidase is what the MAOI stands for, and then inhibitors. So we're going to stop that enzyme from working. So if we stop that enzyme from breaking down dopamine, we're going to have more available for the brain to use. So we use these after someone's usually already on carbidopa, levodopa therapy, we'll add these on. So these can help relieve those motor symptoms, maybe that aren't being fully controlled with the carbidopa, levodopa, or help not have as many of those off times. So generally we see this as an add-on therapy. It could be started initially, but usually people are going to start with the carbidopa, levodopa first, and then this would be added on if that's not effective. So there are agents. The two available in the United States are salicyline or MSAM and rasagiline or Azilect. So you will see these added on. These are generally well tolerated for the most part, and patients don't have severe adverse reactions. So as we saw with the carbidopa, levodopa, we have to keep increasing it. We really don't have to do that with these. Most patients get on a set dose and they sort of stay there during their duration of therapy. So they are well tolerated, but there are some adverse effects that we will see. So reactions could include aching joints, depression, fatigue, dry mouth again, insomnia, that inability to fall asleep or stay asleep, dizziness, confusion, possible nightmares or hallucinations, some flu-like symptoms, which sort of the fatigue, dry mouth, achy joints sort of mimic those flu-like symptoms. Some indigestion and headache are possible. The other thing to think about with these is there's a lot of drug interactions. So you do have to be very careful about the medications that you're taking along with the MAOI inhibitors. So medications that interfere with these, you may have heard of some of these. So Zyvox is an antibiotic that we use to cover drug-resistant MRSA infections. It acts very similar to an MAOI, so you don't want to use them together because you can make the side effects worse. St. John's wort, that's available over the counter as an herbal medication. Tramadol, which is a pain medication, and methadone, which we use for pain also. Cyclobenzaprine or Flexeril is a muscle relaxer. And then the ones that we really worry about with patients, and you'll see it on the boxes because these are available over the counter, dextromethorphan, which is a cough syrup called Delsum, or it can be added into like NyQuil PM, different things of that sort, some of the cough and cold agents. They'll say like, talk to your doctor or talk to your pharmacist if you take an MAOI or if you have Parkinson's disease. So we want to help screen the medications you're taking against some of these over the counters. The other ones are Sudafed, so pseudoephedrine, which is in your classic Sudafed that you have to buy at the pharmacy, and phenylephrine is in the Sudafed that you don't have to go to the pharmacy to buy, so it's called Sudafed PE. Those can also have drug interactions with this drug class. So if you're thinking of taking any cough and cold medications and you're on medications for Parkinson, you're helping to care for someone, go to the pharmacist that is working at the store and tell them the medications you're on, or tell them whoever you're helping take care of, and ask them if it's safe to take this medication. We are more than willing to help you guys figure that out anytime you come and ask us. We'd rather prevent something from happening than have somebody have to go in the hospital because of a drug reaction, because they took something that they shouldn't have taken together. So certainly check with us before you start anything like that. We will help you out. So you can talk to either your physician or your pharmacist at the stores. So if you're wondering, just because we were talking about drug interactions, the Parkinson's Association has a very good medication interaction. Let's see if this will work here. So I linked to it, but if you go to the American Parkinson's Disease Association, they have a very nice handout, or you can search for meds not to take in Parkinson's disease. And it goes through what we were just talking about, those medications not to combine with our salicyline and rasagiline. And then the second page is medications that should be avoided in all patients with Parkinson's disease based on how they work. So some of them block dopamine receptors, which can make Parkinson's worse because we're trying to get more dopamine in our brain. So it lists those medications that might have those dopamine effects. So I just think it's a good document to let you know is out there if you need to check that. So again, but talk to your neurologist, your pharmacist, and we can help you figure out what those are and what drugs to avoid. The next ones we're going to talk about are working on different enzymes that also break down dopamine. So similar to how we saw the MAO worked in two different places to break down dopamine in the products that are made from dopamine. COMT is another enzyme that breaks down dopamine. So it directly works on the dopamine itself to break it down. And then it also works on some of the derivatives that come from the dopamine to break it down. So the COMT stands for catechol-O-methyltransferase, which is just the name of that enzyme that's working. So we're going to stop that enzyme from working. It'll do the same thing as we saw with the MAO, that it will allow more dopamine to remain in the body and remain in the brain that can be used. So these are commonly used along with carbidopa, levodopa. There actually is a combination tablet that contains carbidopa, levodopa plus one of the COMT inhibitors, entacapone, and the brand name of that is called Stalevo. So that contains all three medications in one tablet, so you don't have to take carbidopa separately from the entacapone. So there are other agents. You can get the entacapone by itself. It's called Comtan, and that's probably the most common one we'll see. The tolcapone or Tasmar is not used very much. So it actually has a black box warning from the FDA, which is their strictest warning to people before they would pull a drug off the market, that it can cause liver damage. So it can cause acute liver failure. So generally they would not put someone on this medication unless they've tried other things that aren't working first. And it's sort of I don't want to say last effort, but sort of the last line agent that they would want to start to try and help. The opicapone or Ongentys is very new. It was developed partially by the Michael J. Fox Foundation, which is doing a lot of research and cutting edge stuff in Parkinson's disease. And this is one of the first things that came out of that foundation when it was started, was creating this new agent in this class to help with patients that the others maybe weren't working for. So since that one agent, there was only the two prior, and one of them we don't use very much because of the liver failure risk. So they wanted to come up with another one that was available to help out. So the Ongentys or opicapone is the newest one in the class. So adverse reactions with these medications, similar to what we saw before, we could see sleepiness, nausea, loss of appetite, diarrhea, some dizziness. This one's a little unusual. It can change your your urine to an orange color, which can surprise people sometimes. Hallucinations, some abdominal pain, especially if you're on the one that can cause some of the liver failure. That could be a sign that you're having that liver failure progression. Headaches are a possibility, and some chest pain. So you can see that some of these side effects are a little scarier, maybe a little more serious than some of the other classes. So we don't start patients on this one. We're only going to add this on when they're already on other medications. And unfortunately, it can worsen the side effects of carbidopa, levodopa. So it's a good one to add on, but some patients just can't tolerate it. And it's one that we would be pretty quick to stop on patients. They might stop the COMT inhibitor and leave them on the carbidopa, levodopa therapy, and then maybe try something different. So it is one that is available. It's out there. We do have patients that take it, but then sometimes we just have to take them off of it because they're unable to tolerate it. All right, so those were pretty much all the ones that work on dopamine. The next couple things we're going to talk about are not specifically working on dopamine. They might be working on other neurotransmitters in the brain that have been shown to have some type of an effect on our Parkinson's disease. So the first one is anticholinergics. So acetylcholine is a very common neurotransmitter, very similar to dopamine in the brain. And some patients need to add on these anticholinergics to help with rigidity and tremor. So we already have them on all the dopamine agents that we wanted them on, the carbidopa, levodopa, maybe a COMT or an MAOI, something of that sort, and we're still having some rigidity and tremor. We can add on these anticholinergics to try and help. So it's never going to be used by itself. It will always be added on to other Parkinson's medications. So we will use these most commonly, again, in those early onset Parkinson's disease patients. And then to add on to help with that rigidity and tremor. So depending on what effects you're having from Parkinson's disease will be whether this is selected or not. We do try to avoid it in some of our elderly patients because it can worsen cognition or processing in the brain. So we don't want to interfere with that if that's maybe something they're already having problems with. Maybe there's some underlying dementia or processing problems that we're worried about. This would not be a good choice for them to add on to. There are two agents that we see most commonly, benztropine or cogentin is added on, and then trihexylphenadil has been around since the 40s, so it doesn't have a brand name because it's been around for so long. There is something that we use to try and remember the side effects for the anticholinergics medication. So we're taught it in pharmacy school, and I know doctors are taught this too. So they say that the patient who takes an anticholinergic or takes too much of an anticholinergic, maybe they take too many tablets, they would be blind as a bat, mad as a hatter, hot as a hare, red as a beet, and dry as a bone. So blind as a bat, it can cause dryness and vision changes. Mad as a hatter, so again, we can see those cognitive problems where the patients are not acting. They seem to have altered mental status. They're not acting appropriately. Hot as a hare, so the patients can get flushed and can get very warm, hyperthermic. Red as a beet, so along with the being hot, their skin can also flush and turn red. And then dry as a bone is very common with anticholinergics, that people get dry mouth, dry eye, and possibly like even to urinary retention where they're unable to urinate. So that would be a sign that they would not be medications that we should use for that patient. Sorry, I got this box that popped up on my screen here. Hopefully you can't see it. And the next one I want to talk about is amantadine. So amantadine is a very unusual medication. We are not entirely sure how it works. So we can use it to, I'm sorry, I don't know why this is popping up here. I'm sorry, to help rigidity, resting tremor, and fatigue in our patients, because amantadine can wake you up and get you almost a little hyper. So if you're having problems with fatigue and tiredness, the amantadine can help with that and combat it. There is limited evidence of its benefit in Parkinson's disease, but it has been tried and some patients do well with it. So we will see it used or added on, but again, it's not going to be used usually by itself. It's going to be added on when you're on other medications already. And again, as I said, we're not entirely sure how it works. So we don't know what exactly it's doing in the body to help with the Parkinson's disease, but we do see results from it. So we will use it in certain patients. It's also available in many different dosage forms, so tablets, capsule, and liquid. And most patients tolerate it fairly well. The major adverse events we see with this are possibly hallucinations, confusions, insomnia. We talked about if it does the opposite of fatigue, it can make you a little too wired to be able to sleep. We can see some of the leg swelling that we saw with some of the other medications, nausea and vomiting again, and then nightmares and agitation. So again, if we see those would probably be reasons to stop using this medication in the patients. The last one I want to talk about is something that was developed just for Parkinson's. So as we saw in that table of drugs not to use in Parkinson's patients, a lot of the drugs that are called antipsychotics, so things that are used to treat hallucinations, delusions as the Parkinson's progresses, or maybe they also have some additive dementia. We can't use most of those medications in our Parkinson's patients because they work on dopamine in the brain. And since they're causing less dopamine in the brain, and we're trying to do the exact opposite with our Parkinson's patients, we can't use those. So they actually made a new drug called Nuplazid. The generic name is pimavanserin. So this was specifically designed just for Parkinson's patients to be used in those cases. So if they're seeing psychoses, hallucinations, delusions in some of those patients, this was made to be a unique drug in its class that doesn't work on dopamine. So it can be added on to those patients that are having those symptoms. It's unique, it's fairly new, it has not been out very long, and it can help for people who are having those symptoms. So again, a lot of the drugs we saw had that as sort of some of the side effects. We saw hallucinations in multiple drug classes that we talked about. And then just as the Parkinson's progresses, sometimes there's other underlying issues in the brain. There's a need for this drug out there. So it was developed just to be used in this patient population. So it's nice to know that there is an option if we do have to add that on, that this is there and available now. Before, they would just have to try other things that were not very effective. But this drug is much more effective and can help the Parkinson's patients. So those are sort of all the drug classes I want to talk about. Those are our major ones that we're going to use and that you'll see used in our Parkinson's patients. Now I want to talk just a little bit about some newer options for some of the older medications that we have been seeing. So one of the ones we're going to talk about is a new technology that has come out for the use of carbidopa-levodopa. And the other one is a different dosage form of carbidopa-levodopa that is new. So the first one we'll talk about is called duodopa, or you'll see it called duopa. This has been used in the United Kingdom and Canada for Parkinson's patients with some pretty good results. So just as a background, so over time, Parkinson's has a negative impact on gastric emptying. So just the transit of things through your stomach slows down. So food stays in your stomach longer and doesn't move into the intestine. Most drugs are absorbed in your intestine. So they may start dissolving in your stomach, but they need to move into the intestine to be absorbed into the body to work. So the longer it sits in the stomach, it takes longer to get to the intestine where it will actually do some good. So this can obviously affect our oral medications that we're taking because they're not where they need to be absorbed into the body where they can actually work. So this was developed to be a non-oral therapy, so it's not taken by mouth. It is still carbidopa-levodopa. It's actually a gel that gets delivered through a tube and a pump straight into your intestine. So it's still a similar medication. It's doing the exact same thing that we saw the carbidopa-levodopa doing. It's just a different form. So it's coming to the United States. It's made by a company called AbbVie, which makes a lot of specialty medications for different disease states. And I found this was something that was drawn by a patient in the UK who uses the pump to try and explain to his friends and family how it was working for him. So this is how he says, how I get pumped every day. So you can see the little blue and white is the pump itself. Then there's tubing that comes out of the pump and is going into what's called a PEG tube or a percutaneous endogastric tube into the stomach. So there's a hole made between the stomach and the outside abdomen. And that's what you see here. It's sort of attaching into the stomach. And then the tube itself, you can see, is ending in the intestine. So it's going through the stomach into the intestine. So the drug is pumping from the pump through all that tubing and coming out the end into his intestine. So it's missing that whole thing we were just talking about how the stomach is slowing down, things sit in the stomach too long. It bypasses all of that by being delivered exactly where it needs to be delivered to the patient where it can be absorbed right away. And also because this is a continuous infusion, this runs all the time, they see less off time. So we talked about how the patient can have where the drug seems to wear off. So because it's not a tablet where you're taking it, it's being absorbed and eventually it's all eliminated from your body and you have to take more tablets and keep doing that. This is being constantly delivered into the intestine. So it's constantly being absorbed in a set rate. So it actually can help with the patients not having to use as much total daily dose of the carbidopa-levodopa because they're just getting a small amount all the time, which can be very beneficial for patients, especially ones that have those severe on and off times throughout the day. So this is new, it is coming out there. It does require a surgical procedure to place the tube into the stomach. And then obviously you have to be taught how to load the cartridges into the pump, how to troubleshoot kinks in the tubing, how to take care of everything so that you don't get infections and things of that sort related to having the tube into your stomach. So there is a lot of education that happens for those patients to be able to use the pump. And then the cartridges are delivered from the specialty pharmacy in coolers. So you have to have space to keep them. If you're traveling, you'd have to take it with you in a cooler to take with you. So there are definitely some considerations where this may not be the best option for some patients, but for people who are able to use it, it can certainly be a good option. The next one I want to talk about is just called Divvy. That is how you say it. So it says like D-I-V-V-Y is how you would say it. So it's a carbidopa-levodopa tablet that you can snap apart. So rather than having to take a tiny little tablet, put it in a pill cutter and cut it with a pill cutter, If you're having motor issues, or maybe you have a little bit of a tremor in your hand, or you're not as steady as you used to be, you may not be able to get that tiny little tablet into a pill cutter and cut it. So this tablet is specially designed to be easy to break apart. And you can cut it into 4 pieces. So you can do a smaller dose of carbidopa levodopa than maybe what was available before. It's very hard to cut a small round tablet into quarters and have each quarter be exactly the same size. So this was specifically designed that you could snap it in half. You could snap off just 1/4 and take the 3/4, or you could take the 1/4, and then you would just put the remaining tablet back in your bottle and use it later. So you could take, say, for instance, one tablet was the 2500, which is similar to what we see with the Cinemet or the normal carbidopa levodopa tablets. So you could take one tablet, you could take 1 3/4 tablets, you could take 1 1/4 tablets, and it would be something that's actually measurable and is easier to use. So you can see it's not exactly to scale, but the picture with the person holding it, it's a bigger tablet that you can break apart. So maybe you could take a regular Cinemet tablet and then use this to make up the different doses if you're taking the 1/4 tab, 1/2 tab, or 3/4 tab. So this one is pretty new, and it was designed just with a Parkinson's patient in mind, knowing that they might have problems with breaking tablets. So the next thing I just want to touch on real quickly are things that are coming up. So potential therapies and what is out on the horizon for the medications and possibly different options that are there. So some of these sound a little, I guess, science fiction. But the first one, gene therapy using a virus vector. So they actually, within the last week, the FDA has approved the first drug ever using this technology. It was developed for hemophilia patients, and it has the potential to cure hemophilia for the first time ever in history. So they take a virus, they target the virus to, specifically in this case was the liver cells, and they put a gene inside that's lacking in the hemophilia patients. So this virus, when they inject it into the patient, it's a quick infusion. It's really only, I think, like a 1/2 hour infusion. They get this 1/2 hour infusion, the viruses travel to the liver cells, they inject these genes into the liver cells, and then when the liver cells replicate and make copies of themselves, this gene is now included that was missing. So essentially, hemophilia is that this gene was lacking. Now they've cured this patient because all their future liver cells are going to have this gene where they don't need hemophilia treatment anymore. Unfortunately, it's very expensive. They estimate that it's going to be $3.5 million for the treatment, but it would be a one-time option that would cure hemophilia. They are looking at similar technologies for Parkinson's disease and various other diseases too. But that is something that is actively being worked on and actually now has been approved by the FDA as a potential treatment option. Stem cell approaches. So you've probably heard about stem cells. We use those in our cancer patients currently. So those are out there. Oh my gosh, I hope this doesn't do this. It's telling me my computer is going to restart. I hope it doesn't. I will call back in as soon as I can if it does. But the stem cells are being looked at as options. There's also new proteins. The particular one that has been looked at so far is alpha-synuclein, which has been implicated in the pathogenesis of Parkinson's. There are vaccines being targeted to Parkinson's patients and antibody treatments. So those are all.
Looks like her computer rebooted like she thought it might. So just hold on a second. I think she was ready for Q&A. So.
Okay, I am so sorry. My computer died. It forced a restart.
No worries. We did get some questions pop up while you were rebooting. So the first one is the cartoon of the neuron and receptor suggests there are 3 types of dopamine receptors. Are they all the same, or how many are there? Do medications have to hit all types of receptors to work for Parkinson's?
There are different dopamine receptors. So there was a reason it had the 3 there. There are different types of dopamine receptors, and different agents may work on different ones. So some of the drug interactions that we saw in that one document work on the D2 receptor. Each of them are different. So There's ones that are primarily in the brain. There's ones that are more in the body throughout. So the drugs that we use focus primarily on the ones in the brain, which if I remember right, are the D1 receptors. D2 are also in the brain, but they're responsible more for the psychoses that we talked about. So those antipsychotics work on those. And then I think the D3 receptors are throughout the body. So dopamine can get taken up in the like your muscles and different parts of the body, not in the brain. But we're focusing our drugs primarily onto the ones in the brain. So that's why we're so concerned with getting the drug to cross the brain. So there's something called the blood-brain barrier, which makes it hard to cross. And that's why we combine that carbidopa, levodopa together to try and get those drugs crossed over to where they need to. So they don't have to work on all three of them. We do target the drug specifically to the actions we want on those certain receptors.
Next one was new patient, not on meds. Have long time gastro. How does one coordinate treatment?
So every patient is different. So that's one of the things that the neurologist you're working with should be helping determine. So there may be drugs they don't want to use because of delayed gastric emptying. There's some drugs we can try to help decrease or increase gastric emptying, so stop that delay. So every medication and regimen is going to be specific for each patient. So the regimen that you're on may look different than when someone else is on. And that's one of the things that your neurologist will work with you to do, is to get, where you need to be. So if you have a good neurologist that you trust, they should be able to work with you and help identify which form would work for you. So maybe you're somebody that needs medication in patch form, or the tablets that can disintegrate on the tongue, or the films that disintegrate on the tongue. That's one of the reasons there's so many different options out there, because patients are so different.
Okay. Regarding essential tremors, not specifically being classified as early onset Parkinson's, is there noticeable symptom management with the carbidopa levodopa use?
If it's truly an essential tremor, I have seen doctors, if they're unable to identify if it's essential tremor versus a Parkinson's disease, because unfortunately there's not a quick test we can just do to say, oh, yep, you have Parkinson's. They rule out everything else and say, well, that's the only thing that's left. So sometimes they will trial a Parkinson's medication and see if it helps. And then that might lead them to be, okay, the diagnosis is Parkinson's disease. If that doesn't work, then the diagnosis may be more towards an essential tremor, which is managed with different medications in different ways. But that is something that you will see neurologists do to help try and diagnose what actually is happening with our patients.
Great. Next question is, when taking dissolvable C and D, is it best to take it with liquids or without?
If you're taking one that dissolves on your tongue, usually we say without, because you don't want to wash away any medication that might be left. So usually you want to wait about 10 minutes or so after you take a dissolvable medication to make sure it actually gets absorbed.
Any medications to address cognitive and especially spatial issues such as sense of direction?
Probably not. Unfortunately, there's so many things being worked on. I wish they could have a medication to fix everything, because I know that can be very difficult. I think a lot of that can be dealt with more along the lines of like physical therapy.
Occupational therapy.
Mm-hmm. Yeah. So sort of add-on stuff. Unfortunately, there's not a lot of great medications I can think of that would help with that.
Is there a best medication for restless legs?
That one is also patient specific. So some of the ones we talked about, those dopamine agonists that we talked about, so the pramipexole, ropinirole, those are commonly used for restless legs. But sometimes it does depend on exactly what's causing the underlying problem. So some patients are deficient in certain minerals and vitamins, and if they fix that deficiency, the restless legs goes away. Other patients, they need that additional dopamine. So there are some other things that they should be testing for just to make sure before you jump straight to a medication. So if there's like a vitamin deficiency or something, they could hopefully test for that. Some patients are deficient in magnesium or potassium, and then if you fix those, then the restless legs goes away. So I can't say there's one specific medication that's the best for that all the time, but you will see those dopamine agonists being used for that very commonly.
Great. Next question is, I'm new to carbidopa levodopa. How long do I need to wait to eat after taking? Her doctor says 30 minutes. Also, the issue of eating too much protein. Can you please explain?
So one of the things, okay, so two different questions there. So the half hour is usually about right, but it does again depend on what form you're taking. So the immediate release versus extended release, sometimes those will have different considerations based on if it's tablets or capsules or things of that sort. But usually with any medication, if that should be taken on an empty stomach, about a half hour before eating or 2 hours after eating is usually about pretty normal. And then the second half was, I think,
and then
protein.
Yeah, the issue.
Yep. So if you eat a lot of protein, it actually slows down the transit through the stomach. So we were talking about how Parkinson's can do that initially all by itself. So if you eat like a heavy protein meal, you'll feel it sort of sits in your stomach. It doesn't seem to move through very quickly. It's because that's really what's happening. It slows down how fast it moves into your intestine and gets broken down in your stomach. So if you eat a huge amount of protein, like you eat like a giant steak and then take your pills, they're not going to move through the way they need to.
Options for therapy directed at delayed gastric emptying.
So there are a couple medications that they will use. There are some, they call them prokinetic agents that sort of help move things through faster that can be tried. One of them is an antibiotic. You take it at a very low dose called erythromycin. There's some anti-nausea medications that they can try that sort of help move things along. And there actually is a gastric stimulator that can be implanted that can cause that to happen. So it causes contractions of the stomach and the intestines to make things move through faster. So there are some other options that can be out there, but sometimes you can help with, what you eat. Not a lot of protein, not high fat diet can help things move through faster too. So there's a few different options that are available.
Maximum dose of carbidopa levodopa daily one could expect.
I don't know if they found it yet. I've seen patients on some pretty big doses. So I don't think they have. I was just looking to see if they have a. So the levodopa component, there's some talk about 2.4 grams a day, which would be 2,400 milligrams. If you're taking like a 100 milligram tablet or a 250 milligram tablet, that could be quite a few tablets that you get there. And I think on some patients, they've even been pushing that a little bit higher, because if that had been working, but you have to keep adding on, they may go higher than that. But that's sort of what they say is about a 2.45 grams or 2,400 milligrams.
How does occasional alcohol drinks impact these drugs?
Depends on which one. So alcohol is a depressant in your nervous system. So it makes you sleepy. It makes you, most people get real calm or real relaxed with it. So if you're taking other medications that already do that, or you're trying to do the opposite. So, if we're trying, like if you're taking the amantadine because we're trying to get you more awake and get the fatigue away, and then you're taking the alcohol will do the exact opposite. So it does depend on which medication you're on, exactly what you would see for side effects. But a lot of times it would be sort of working against some of the medications.
Does taking, excuse me, does taking carbidopa, levodopa over time actually speed up or advance the progression of the disease? And what labs should be monitored while on those meds?
So it doesn't speed it up. Really what we're doing is trying to prevent progression. Well, not prevent progression, but slow it down as much as possible. So, but unfortunately, like we're saying, you just have to keep taking more and more because your body gets used to it. So your body starts what dopamine it was producing. It may say, hey, well, you keep taking extra dopamine, so I'm going to stop producing the dopamine I was taking before. And so then you end up having to keep taking more to replace what your body was doing. And then as your body gets tolerant to it, you have to keep taking more. But I think it is probably the mainstay of almost all Parkinson's medication regimens at this point in time. It's still the best option we have.
Someone is wondering if there are any foods or herbs beneficial to PD patients.
So I don't know if we found that there are ones that are super beneficial. There definitely are some of those that we would want to avoid depending on drug interactions. So, that's something I'm sure your neurologist or I could get you in touch with a dietitian if you wanted to talk about. But I can't say there's any that come to mind right away that I would say, oh, every Parkinson's patient should be taking this or eating this.
Sure. Someone is wondering, has it been difficult to get insurance to cover Divvy?
I haven't actually seen anyone on it yet. So I do still work retail every once in a while, but I haven't seen anyone try it. So since it's new, sometimes the insurance companies always have hoops that they want you to jump through to get the, something approved when it's new. But I can certainly see that there is a spot for it in therapy. And I think it might be something that if the insurance doesn't like it, your neurologist might have to fill out paperwork to get them to approve. But I can certainly see where it would be helpful for a lot of patients.
This person's wondering if there are any drugs that focus on mobility and walking issues. Probably again, the PT and OT.
Yeah, definitely therapy. There's a lot of things you can do around your house, to try and make it fall proof and things like that. But definitely, exercising and keeping yourself as fit as possible and having exercises that can help with that. So the stronger your muscles are, the better you would be at balance. There's no medication really that I can say would make it better, but there are definitely medications that could make it worse. So there are things you would want to avoid. So some of those things that could cause dizziness, drowsiness, and then some of the drug interactions that we talked about too. So that again is something, if you're thinking of like a new medication or starting something, you could talk with your pharmacist or neurologist about and make sure that you're not taking something that would make it worse. But I can't say there's anything really that would make it better.
This person said, I was wondering if you have touched on the drug Eldeprel, ELDEPRYL, for their off time. It has a lot of side effects. Plus, I can't have a ton of food that she loves.
Mm-hmm. So I guess I would just have to make sure. So there's one coming up that it's a brand name in other countries for saligeline, which is one of the ones we talked about as an MAOI inhibitor. So I don't know if that's the particular one that she meant or if but it's not a US brand name for it. So I would just want to make sure that that's the one she was talking about, or if there's a different one that, so I'm not sure. I know we did talk about the MAOI inhibitors, and there definitely are things you can't eat with those. So I'm guessing that might be the one. Foods that are high in tyramine or specific amino acids, they can't eat on there. I didn't go into that a lot, but there certainly are medications that are foods that they need to avoid. So if those are some of the ones that they like, unfortunately, that isn't the not much you can do with that. There's a possibility maybe they could try a different class if she's, if they're unhappy with the restrictions, that they could maybe
Sure.
a different one.
I'm not sure if you can read the next one because I don't want to even attempt to pronounce, but someone is wondering about a mix of the carbidopa, levodopa, and
Sageline and tocopone and pramipexole.
Yeah. Does that sound extreme?
I have seen the mix before. So definitely that carbidopa, levodopa we were talking about, and the atocophone is the COMT. They're all in different classes. So there's no duplication happening with that mix. So I could see, adding things on as we're progressing, and the carbidopa, levodopa isn't working, so we'll add on the atocophone, and then that worked for a while, that's not working, we have to add on. So sometimes in some of those early onset Parkinson's patients that are on medications for decades, they end up on regimens like that because the symptoms are not manageable. So, but as long as they're, we're working in all different ways. So it's not like we're having two from one class where I could say, well, those two are doing the same thing. Those are all different. So I could see it as a possible regimen for someone. It wouldn't surprise me.
All right, we have time for just a couple more here. You mentioned the development of vaccines. Would the vaccine be used to prevent development of PD or used in other ways for a person with Parkinson's?
So as we learn more about the actual brain chemistry changes that happen in patients with Parkinson's, what they're doing in some of like the cancer trials is they're targeting vaccines towards specific proteins or towards specific cells in the body that maybe could cause patients to develop cancer. So the same thing has sort of been looked at. So if we can isolate, like, well, maybe this, people who have an excess of this particular type of cells or things like that, and we could develop a vaccine against that cell. So there's a lot of different avenues they could go down with the vaccine route that are being tested. So those are definitely in trials and being worked on, but I don't think they've actually gone to human trials in any of the vaccines for Parkinson's quite yet.
Okay, is there a best medication to fight hallucinations?
So that one we talked about, that Nuplazid, is probably the best one that we have right now for the Parkinson's patients. So it was developed just for that reason, because we see that as a side effect with so many of the medications. And if you develop dementia along with Parkinson's, you definitely get those hallucinations. I know my father particularly had a lot when they started increasing his doses of carbidopa, levodopa. Whenever they would increase it, he knew the things weren't there. He was hallucinating, and he's like, I know there's no one sitting next to me, but in my brain he's there, but I know he's not real. And that would be probably the best one that we have right now. Would be that Nuplazid or the pimavanserin.
Does any drug help with extreme dyskinesia?
That one's hard. So I can't say there's one that would be the single best one. It may require a combination. And it sometimes may take a little bit to find which combination of medications and doses make that the best. So again, that's something your neurologist will probably have to work with you on. So there's a lot of different options out there. And then again, they're working on things all the time that hopefully we can come up with something better. I know there's not a lot of great options right now.
And then someone's asking if there's any problems with yogurt and cheese.
So that goes back to that MAOI class of medications, and that there's certain ones that you can't have. So some of the aged cheeses, certain kinds of yogurts are ones that they shouldn't be taking along with those. So if you're on one of those medications, there can be an interaction there where they ask people to not eat certain cheeses and foods. Ones containing tyramine are the ones that are usually implicated. And usually they'll give you a list with the, if you take that medication, they'll give you a list of foods to avoid.
And then the last question will be, are time release carbidopa, levodopa a better choice than standard?
It depends on the patient. Some people take a mix of both, where they might take the immediate release during the day. So when they start having symptoms, they could take the immediate release because it starts working right away. But then they'll take the extended release as sort of they'll alternate. So they might take an extended release like 3 times a day, and then in between they can take the immediate release if it starts to wear off or they start having those off times. I know for my father, he would take the extended release at bedtime, because if he took the immediate release too close to bedtime, he had horribly vivid dreams that he couldn't wake up from, and then he'd got no rest. So he'd take the extended release so he didn't have those dreams happening throughout the night. And then he would take the immediate release during the day when he was having symptoms. So there are people who use both, and there are definitely places in therapy for both of them. So I
And
wouldn't
I'm
say
sorry.
one's better than the other.
Okay, great. And I'm sorry, this is actually the very last one. Anything in particular to be aware of with Nuplazid?
I mean, with any new medication, you want to make sure and talk to your physicians about drug interactions and make sure that everything has been looked at with that. A lot of people tolerate it really well, and it can help with like we're talking about, the hallucinations and some of the psychoses and things. There are some cardiac issues sometimes that they want to do with it, so they might have to screen you for those just before you would start the medication. But if you have a healthy heart, there shouldn't be any problem. But that would be the biggest one I could think of that people would want to get checked out before they would start it.
Okay, great. Wow. Well, that was a great presentation with some great questions too. Thank you so much. So thank you so much for all of you that attended. And thank you, Jennifer, for your great insight and answering all those wonderful questions. And I hope everybody has a great afternoon. Thanks again.
Thank you.